Thank you, and I want to thank the leadership and staff of Can Health Infoway for honoring me by asking me to come talk to you. I think many of you have probably heard me talk before. I think most of the information I'm talking about today is new. There might be the odd bit or two that people have heard before, and if you've heard some of this before, I apologize in advance for that. But I am going to be talking about achieving excellence in healthcare. I try to leave some time at the end for questions, so I'll try to keep moving and not get caught up in some of the details. But I want to focus on applying what works. I say we're the group here in the meeting, and many of us across the country, a relatively small community of people who work in these areas. I think that sometimes it's not always recognized how instrumental the kind of tools we provide are to achieving excellence. So I'm going to focus a little more on that today than some of the things I've talked about in the past. So I'm going to spend a little time introduce this with a perspective of mine about what we're trying to do. I always like to begin rounds with the case. Once again, I think some of you may have seen this case before, but if not, I think it'll illustrate things. So I'll do a couple cases to sort of frame where we're going with this discussion. My bullets here are very long. Why does the simple concept of excellence have such trouble gaining traction? How do we align our staff with our vision for excellence? I'm hearing a lot of talk recently about patient safety culture, which I think is appropriate, but I think that the people in this room and other colleagues of ours have a stronger idea about how we achieve a patient safety culture than perhaps some other areas of healthcare. And then I'm going to give some examples of a successful improvement in clinical workflow. Normally I spend these talks discussing workflow in great detail. Many of you have seen my little flow charts and diagrams of workflows and stuff. I'm not doing any of that today, but obviously there's a lot of detail that I'm not going to be covering, but I thought that we would change pace a little bit today. Okay, so Trevor and I were talking about this yesterday, actually. Everyone always says that fixing healthcare is like boiling the ocean, right? You can't do it. In fact, I think I wanted to pick up on Trevor's remarks just a minute ago. The medication issue with regard to interoperability and how we solve medication utilization, medication reconciliation, and e-prescribing is a boiling the ocean problem. My perspective is a little different. You can boil the ocean. You very much can. Oceans boil 1 degree at a time, and that's what I'm going to be showing. A lot of people in healthcare think that excellence is some magic bullet. You just do one thing and suddenly, if we just got doctors to care about patient safety, that somehow it would all get better. That's not the case. Healthcare is a big ocean. Boiling it is going to take us moving 1 degree at a time. This is Kilauea, as anyway, everyone must know, which is currently boiling the ocean off of Hawaii right now. So let's go do some cases. I say in medical rounds, we always like to use cases to frame the discussion and move from the abstract to the concrete. So just to remind you, I say I don't think I have to remind anyone in this audience about it. Patient safety has been identified and highlighted by studies familiar to all of us for several decades now. The Harvard Medical Practice Study identified adverse event rates at 4% of hospital admissions. The Institute of Medicine report, once again familiar to everyone in this audience, right? To Erris Human, 98,000 preventable deaths due to medical error per year in the United States. And Peter Norton and buddies did the Canadian Adverse Events Study follow-up, and they found 7.5% hospitalizations, and they got a figure between 9,000 and 23,000 preventable deaths per year in Canada. So this is all very consistent. The data is old. We have lots of it going back now, and we arrive at numbers which are basically the same, right? It's not 20%, but it's not 0.1%. Serious things happen on a fairly regular basis. And no other industry tolerates failure rates of this magnitude. Right? Why is it so hard to get, does excellence have such difficulty gaining traction in healthcare? If I have to fly back to Ottawa tonight, if I thought that there was a 4% chance that something really bad was going to happen on that flight, I would be taking the train, right? And so would all of you, right? So, okay, airline, it's a cheap illusion. Okay, pick any other issue. Product quality. I'm old. I remember when you used to buy lemons, products that didn't work when you bought them. I remember those days. That doesn't happen much anymore. And the quality assurance processes that other industries have. I own a Toyota. We get every once in a while Toyota says, "Oh, we're recalling this part. Bring your vehicle in to get repaired." They are extremely proactive about maintaining their products because they have strong quality processes in place. Do we have any of that? We don't have any of it, right? Considering these rates of error, right? The rates of error are symptoms. That's not, we're going to discuss that in more detail. I don't want to harp on this, but it does frame where we're going. This is a symptom that we do not understand quality and excellence. Okay, let's move from our abstraction to the specific. Let's do a case you said elsewhere. Once again, some of you may see I've used this to discuss this case before. This is Louis Blackman. He was a 15-year-old boy who undertook elective chest wall surgery at another hospital, in another place, another time. Louis bled to death internally over the course of 30 hours post-operatively. During this time, the nurses and residents looking after him ignored worsening abdominal pain, distension, pallor, and severe tachycardia. For the last 2 hours of his life, his blood pressure was unobtainable while staff tried different blood pressure cuffs. Reading the coroner's report on this, you can't believe what you're reading. You really can't. Louis is one of those 98,000. Oh, you're saying to me, you found the one case. You picked a bad case that's really public and makes you sad, so I just picked one out of the blue. I know a bunch of others. Alicia Shore, Trevor Landry, Claire Lewis. The list goes on. I can find more if you want. But okay, let's bring it back. Another case, perhaps not as far away as Lewis. Mr. Jones came in with a bleeding ulcer to a hospital I know. He spent the day in emerge, wait time's an emerge thing, right? Waiting for endoscopy. He didn't get to the inpatient floor till 8 p.m. 2 units of blood were sent up from the blood bank at 11 p.m. And after careful verification of the blood units, they were transfused into Mr. Smith, who was in the next bed. Now, as many of you are aware, if you transfuse the wrong blood into someone, if they have preformed antibody to that blood, their body will attack and destroy the blood within minutes, creating a lethal or potentially lethal immune reaction in the bloodstream in a very short space of time. If they don't have preformed antibody, they will create antibody against the blood, and since blood cells live 90 days, the blood cells will hang around plenty of time for the body to develop an immune reaction against that blood and destroy it. Fortunately for Mr. Smith, by a miracle, his blood type matched Mr. Jones, and he did not develop a reaction to this blood. He did not become one of the 24,000 Canadians who die per year. But it's all real. We're moving the abstract to the specific. What was the response to Mr. Jones, Mr. Smith? Let's think about it. The Ottawa Hospital has very clear policies on procedures for double-checking blood transfusion. They're on our internal website. They're very well known. People are trained on them. And after this event, the only reason I found out about the event, was that the blood bank team went up and did an in-service to remind people to be extra careful to follow the procedure. Really? That's your plan? You wonder why it's 4, 5, 6, 7%. Perhaps we have policies. Every hospital, every healthcare system, every jurisdiction has policies. It's not working. Let's talk about why. Why does the simple concept of excellence have such trouble gaining traction in healthcare? It's going to take me a little while to explain this, but let's go through it in pieces. These are our Ottawa Hospital quality indicators. These are posted, they're listed. So there's actually the board of the hospital has a web page that shows these and so on, and they're all red because they're not good, and everyone's unhappy and so on. Look harmless. What do you want me to do? WTF, I don't have anything to do with these. I go, yeah. Occupancy rate, yeah, so what do you want me to do? I'm a frontline healthcare provider. I give lots of care to patients. Yeah. Doesn't do anything for me. I get a message every morning about how terrible the occupancy rate at the hospital is. Right? Ottawa Hospital is sitting at 110% occupancy right now. I get emails telling me this. Yeah, so I've got 40 patients in hospital right now. So, what do you want me to do? Readmission rate, yeah. Tell the team, we're fussing with Mrs. Smith. I go, yeah, okay. She's going to be back in 3 weeks, guys, relax. Send her home. She'll be back in a March. Don't worry. Yeah, but what about this dose? We'll figure the dose out when she returns. It's okay. Just send her away. She'll be back. Wait times, yeah. Cutting down access to CT and MRI scans to balance the budget. Okay, wait time's not going to get any better. What do you expect is going to happen? We'll talk about that. Here's the Excellent Care for All Act, patient safety indicators, and I've already got the little flag up. Well, what the hell do you expect me to do? C. diff rates, yeah? Yeah. What do you want me to do? It is difficult for me as a frontline healthcare provider to act on any of these things. They don't mean anything to me. I know they're bad, but the action I'm supposed to take and the compliance you're expecting from me is unclear. It's not that they don't mean anything, but it's hard for them to mean something to me as a frontline staff member. So many people cotton on to Lord Kelvin saying and others, you cannot manage what you cannot measure. True. But let's not make any mistakes here. Measurement is not the same thing as management. You can measure all those things at the hospital level. You can measure all those things at the healthcare system level. That's not enough. People confuse this and say, well, I'm measuring stuff. We're measuring occupancy rate. Why doesn't it go down? We're measuring post-op infection rate. Why doesn't it go down? Well, you haven't done enough work yet, have you? So, how do we align our staff with our vision of excellence? This is the Ottawa Hospital vision statement. I'm very proud of it. It's a great vision statement. Provide each patient with world-class care, exceptional service, and compassion we want for our loved ones. Sounds good. But like those quality indicators, the actions that we are expected to do to live up to this vision are not necessarily clear. They may seem obvious to various people, but if you polled a whole bunch of people, I suspect you'd find that the actions you expect people to take might not all be the same. So we're not aligned. We all agree with the statement because it's a motherhood statement. We're not aligned, nor are we aligned to those master indicators that the hospital has. Well, what could we be aligned with? The Ottawa Hospital will achieve its vision by meeting patient expectations 100% of the time. Think of indicators this way. Okay? Think of a hierarchical model of indicators. Right? This is how real industries, these are tools that work in other places. So those metrics I just finished talking about, the ones in the middle there, outcome metrics. You can't hold me accountable for those. But each of those metrics is tied to a whole series of metrics underneath it. Okay. Doing my consultations to emerge promptly, prompt specialist consultation to emerge. Well, that you can measure, and that you can hold me accountable for, and that might have an impact on waiting times. Okay, so if you start decomposing the metrics and decomposing excellence and decomposing safety into things that frontline staff can do, now we're starting to get closer to what it's going to require. And everyone in the room is going, oh yeah, that's what we do. Information, data, yeah, that's what we generate. You see where we're going here? This is the kind of infrastructure you're going to need to deliver excellence. People ask me, why doesn't lean work in healthcare? I go, lean will work in healthcare like everywhere else. But what you're going to need that healthcare does not have, that other industries do have, is indicators. Atomic, low-level, highly granular indicators. Don't come complaining to me about the hospital-acquired infection rate. But you can come to me and say, Glenn, you only washed your hands 40 times today, and by our count, we think you should have washed your hands 80 times yesterday. All right, is anyone else? And your colleague over here, he washes his hands 80 times a day. Oh, okay. I now see how I might be connected to hospital-acquired infection. But just publishing a gross number for the organization does nothing for me, and no other industry attempts to manage their staff and the quality of the service they provide using macro indicators without having a series of micro indicators underneath them all. Healthcare will be the only place where we attempt to do this. It won't work. We've seen that it doesn't work. That's how we end up with the kind of adverse event rates that we do. So you're going to need a whole series of highly granular metrics, which then get presented back to frontline providers. It may not be fun for me to be shown that I don't do my emerge consults as quickly as somebody else. That's not a fun discussion for me. But it's a highly motivating discussion. Okay, well, I guess I better work a little harder to get there more quickly than I was before, right? Do we manage to see how clean the rooms are? Do the house cleaning staff get audited? Do we send somebody up after the house cleaning staff have been there to swab the rooms and see if they meet the requirements of cleanliness? I think not. Doesn't get done. So let's think, instead of using a simple model of measurement and management, let's be more specific. What gets measured gets done. What gets measured and fed back gets done well. What gets rewarded gets repeated. It's a better way to think about it. Highly granular metrics that give people immediate feedback on how they're doing at their level that are meaningful to them. Like to stay, not very meaningful to me. I don't keep people in the hospital for the fun of it. So use metrics and drive this discussion from measurements that are applicable and relevant and timely to the people involved. Once again, this room, people in this room are the kind of people who know all about metrics. Know exactly how to do this. This is why the kind of things we're talking about are foundational to where healthcare, hospitals, and other organizations are trying to go. How do you build a culture of patient safety? Been a lot of this lately. And it comes across, the discussions I'm hearing make it sound like pixie dust, right? We're going to sprinkle some patient safety. I've seen these discussions. One of the patient safety gurus was talking to the surgeons about sample mislabeling, pathology sample mislabeling in the OR. And he was very hurt that the surgeons weren't receptive to his discussion. And if you know surgeons, when they're not receptive, they say what they mean in very specific terms. And he was hurt. And I'm going, okay, do you think they're trying to do anything bad? Do you think they're trying to make a mistake? Let's turn the heat up on the ocean a little more. If you wish to change this process of sample labeling in the OR, you're going to need a closed loop sample labeling process implementation in the OR, full stop, end of story. You are not going to achieve anything by nagging them to do better. That's not what patient safety culture is all about. Nagging is not it. redesign a process and measure that the process is being complied with, that will do it. And will be less offensive to the surgeons. So no, pixie dust is not going to work. Right now, the primary control for patient safety and healthcare quality rests on a professionalism model. And I call it the pyramid of elephants on the ball. It was actually a real picture I wanted to use from Dumbo. The premise is that if you tell a group of professionals what to do, they will do it correctly without oversight all the time. Does any other industry believe this? The airlines don't. The car companies don't. The banks don't. Professionalism alone is insufficient. But this is the model we use. Because health care workers are highly educated, we think the only approach to quality safety is more education. And we're kind of fans of Aristotle here. What we are, what we repeatedly do. Excellence then is not an act, but a habit, right? Coaches and professionals have been using this kind of Aristotle thing for years. I understand what Aristotle is saying. I don't think if Aristotle were here today, he would be advocating that alone as the means to achieve our goals. Because it leads to this. The model we use is don't ever forget to, reminders, cueing, education. After Lewis died, what do you suppose leadership MUSC did? They yelled at everybody. I'm sure everybody cried. They said, don't do that again. They probably wrote some extra policies. Check on your patients more carefully. Think that works? If you had an error rate of 50%, yes, you want to have a gross error rate, you want to educate people, and you can chisel it down from 50% down. But when you get down to 5%, 1%, and low numbers like that, you've reached the limit of what human memory and reproducibility are likely to do for you. Every other industry knows this. This is the environment we're trying to educate people. Remember to do this. Don't forget to check the vitals. Don't forget to do this. In an environment where the care team members have a lot of stuff on their mind. And it's not very organized, and it's relatively chaotic. Nursing staff, it's the same. Did they mean to transfuse the blood to the wrong patient? Going up and telling them afterwards, don't do that again. Okay, I'm not sure that's going to work. So let's go back to where the cultural safety idea really came from. Institute of Medicine said this in '99, right? They urged health organizations to create an environment in which safety becomes top priority. Okay, that's easy, motherhood statement there. Stress the need for leadership by executives. I don't think there would be a healthcare executive or clinician in the room, in the country, that would say they don't believe in safety. The surgeons certainly didn't when they were being nagged. In particular, it urged that safety principles known to other industries, here we go, be adopted, such as designing jobs work conditions for safety, standardizing and simplifying equipment, supplies, and processes, avoiding reliance on memory. Health organizations are full of reliance on memory. That's all we do. Because there are no metrics, there's no tools, there's no technology, so it's all memory, the whole thing. It's being sustained by professional obligation and memory. Don't forget to check the vital signs. Don't forget to check the medications. Don't forget to double check the blood. It's all based on memory. Well, the Institute of Medicine told us in '99 that's not going to work. Which brings us back to you. You can put the systems in place that help people by simplifying and standardizing, by avoiding reliance on memory. But I want to be clear, that does not mean I don't believe in education. It does not mean I don't believe in setting standards and having professionals. That's not it at all. But rather, professionalism is a poor tool if you want to reinforce a process the nurses or the doctors have to do right 100% of the time. That's probably not going to work. So, how do you improve clinical workflow? Let's get some examples. This is my never bring a knife to a gunfight discussion, right? Everywhere in healthcare, I see people bringing knives to gunfights. I go, guys, that is not going to work. Oh, but we don't want to do the hard part. Ocean only boils 1 degree at a time. Do the hard work, but understand that you are boiling the ocean. It is not going to be easy to do this stuff. Certainly in my experience, it's never easy. This model is really, really helpful. This is from Cafazzo and Saint-Cyr. I think they might be talking, Professor Cafazzo might be talking here. The hierarchy of intervention effectiveness. This is a really nice picture. And this is really, once again, what people need to understand. So what the scale represents is less effective strategies at the bottom and more effective strategies at the top. And basically what you know is most healthcare leaders want to play at the bottom. We have a policy against transfusing blood to the wrong people. Yes, I'm sure we do. Everywhere in the hospital, they're always writing new policies. And I roll my eyes, okay, yeah, thanks. Now, fat lot of good that is going to do. The smart money is all up here, right? This isn't my research. This is their research. Human factors in patient safety, right? This is where the smart money is. Everyone in the room should be nodding, yeah, that's where the smart money is. Yeah, yeah. Forcing functions, automation and computerization, simplification, standardization, that's where the smart money is. That's how you're going to do this. Let's go back to the blood transfusion. Once again, everybody in the room knows the answer. Barcode the blood, barcode the patient, scan the blood, scan the patient at the same time. What about the double checking and the remembering? No, guys. Scan the blood, scan the patient, and furthermore, have an audit channel which confirms that the nurses did that 100% of the time. Don't forget the last part, right? We could go even further. We could go all the way to a forcing function, right? We can put an RFID tag on the patient, we tag on the blood, and if the wrong blood is being given to the wrong patient, we can shut the IV pump down remotely and say, I think there's a problem here. I don't think this is right. You've done something wrong. You could go that far. Everybody in this room knows that can be done. That's just technology. It's not cheap. The change management adoption issues, getting a hospital or their staff to comply with a process like that would be challenging. So there may be some cost-benefit analysis you want to do, but it's obvious it could be done. And, you know, frankly, for blood transfusion, it's probably worth it. You go all the way up to a forcing function here. But instead, we stayed down with policies and education, which are at the bottom of this hierarchy. And that's what I see everywhere in healthcare, right? Is everyone's playing with the policies. Ottawa Hospital has thousands of them. We have corporate policies, we have campus policies, we have departmental policies, we have divisional policies, we have professional policies, every level. And when they were looked at, they don't even agree. They are not a very effective tool, and yet they are the go-to tool of most organizations. I'm in committee meetings where they're sitting and writing new policies. I just sign and sit there. Yeah, you could do that if you want. We have a hot policy, the patient will be out by 11. Not a chance. Well, I'm like, yeah. Yeah. No. Not doing it. Not on my list of things to do. So this is a fairly helpful slide, and I hope if there's anything from my talk you take away besides the picture of Lewis, it would be this, is think about it in these terms, because this is what this organization, the focus of people like yourselves is on the higher end of interventions that will deliver more effective, more efficient care. Okay, let's do some examples. As I say, I'm not going to go into the gory detail of all these. There's talks in and of themselves, but just to give you a sense of some of the things. Improving physician documentation. Once again, painful exercise on my part, and I've had lots of scars from this exercise. We've implemented a number of electronic physician documentation tools to standardize the document workflow and to monitor the timely completion of documents. This is important because documents, electronic documents summarizing the patient's care are necessary internally for other members of the care team And when the patients go home, they're necessary to communicate with the community physicians, the primary care physicians, and others in the community so they know what happened inside the hospital. This is a fairly big quality issue. Now, remember, it doesn't show up on that list of hospital indicators. It's not in there. But in actual fact, at a lower level, my hierarchy of metrics is a fairly key metric and one you can measure, and you can then start to hold people accountable. Dr. Geiger, you saw a patient last week, and yet the document has not been sent to the family doctor. You are not meeting our expectations for excellence. Fairly clear, right? Very specific. Yeah, okay, that's okay. And does everyone else do? Okay, someone else is doing better than me. All right. Here's your data compared to other people's data. All right. Does that create change? Yeah, that does it. Right? So we have electronic discharge summary with our discharge medication reconciliation, we have clinical document manager doing physician self-edit, enterprise speech recognition, auto-faxing of documents, piece after piece after piece of this. A whole bunch of components had to be constructed and workflows understood. I'm not talking a lot about workflows today, but workflows had to be understood and changed in order for this to happen. And this is the effect of it. So this is our clinical document manager with auto-fax components. This is the number of documents being generated per month starting back in March of 2012, and you can see the volume of documents increasing over time. So the average time for the family doctor to receive consultations from the hospital has dropped from an average of over 16 days to 3. And the hospital has 5-year savings of $11 million out of this. Another thing that I don't have this bullet on a slide, but I'll say to you verbally, quality costs you less. Quality costs less. Everyone in healthcare, nobody believes this. Quality costs you less. We're producing 45,000. We're on track to produce almost 500,000 documents per year, all done by physician self-edit, speech recognition, and online technology and auto-faxing. You'd like to say it shouldn't be auto-faxing, of course, as we all know, but that's another battle we'll fight another day. Trevor and buddies are going to deal with that, eHealth Ontario and others, but it is what it is. It's a huge improvement, a huge measurable improvement at a low level, low granular level of what's happened. Has length of stay changed? No. Let's not be silly here. But has quality improved? Yes. The e-discharge summaries. I just ran this data last week because I knew it was true, but I had to actually grind the numbers out, and these are what the numbers look like. So the red bars represent our traditional transcribed discharge summaries, and the blue bars represent the implementation of electronic discharge summary at the Ottawa Hospital, right? And you could see the volume of transcribed reports goes down, the volume of e-discharge summaries goes up, right? Remember, these e-discharge summaries are distributed electronic or distributed through auto-faxing, right? So here you can see the volume change. Here's the number of days needed to complete a discharge summary. So back in 2006, I just extracted this data last week, 30 days average to get a discharge summary transcribed and mailed, snail mail, to the family doctor. The patient has already shown up in the family doctor's office, and the family doctor's already gone, WTF, I have no idea what's going on with this patient because I don't have the document. That's the world we were in. Look at what the discharge summary did, right? The average is down to 3 in 2014. It should be 0, as you'd expect. Could we get it to 0? Yeah, because I can tell you who's doing what, whether they're doing it or not, right? We have that data. The data exists at a granular level enough to start holding people accountable for their performance. Now, frankly, you could argue 3 is good enough. I don't know. But the point is it can be measured, and now you can manage because you have the right level to manage it. Big data, yeah, okay, big data, whatever. At least some data. Right? This is what excellence looked like. Now, it's not sexy and neat and saving lives, all this other stuff. No, it isn't. Hard work, years of work to get this to happen, as you can see from this graph. No magic bullets here. Hard to do. The ocean boils 1 degree at a time. Reconciliation. We have worked for really almost more like 4 years on configuring and implementing a standard electronic process for comparing a patient's outpatient medications to their in-hospital medications and vice versa. And Trevor alluded to that, and boy, I would sure like to have some more tools to make this easier, because this has been a difficult fight with the doctors to get this to happen. We have med history components, allergy documentation, clinical whiteboard display of overdue reconciliations. It turns red when you haven't done your reconciliations, right? Admission reconciliation on mobile and desktop, discharge medrec on mobile and desktop, an online dashboard from our data warehouse to show compliance. And this is what you get. The Ottawa Hospital has the highest demonstrable compliance with medication reconciliation in Canada, if not the continent. Don't know the continent statistics. There's the compliance rate. I think this is, I think that's discharge medrec. And the outliers, as you can see, that low bar in the middle is actually our hematologist at the General Hospital. And you can imagine some people are going to have a little conversation with them. Right? A metric that is granular enough to isolate the compliance of individuals and therefore hold them accountable as individuals for the delivery of this item. This is how you boil the ocean. I graph this data, I look at the data where I do it all the time. Right, because it's been an extremely painful project to do with lots of physician anger and pushback to get this far. Really hard to get here. The project matters. At a certain point I get pissy and say, okay guys, you're going to push back to me, I'm going to show you what you should be doing. Safer IV infusion pumps. The Ottawa Hospital replaced its fleet of IV pumps with new smart IV pumps. This enables us to standardize, here's the standardized word, safety. This is what safety is all about, right? We standardize the drug library. The old pumps had drug libraries in them. We couldn't standardize because we needed a sneaker net to do it, right? You need to run around and access each of 1,800 pumps to actually reload the library. And the pumps couldn't be done. Not couldn't be done. We didn't do it because it was impractical. For the new pumps, that's not the case. They are Wi-Fi enabled pumps. You can update the library in them directly. We are now using hard stop dosage alerts to prevent medication administration errors during the programming. This is one piece of a much larger medication safety strategy, like the MedRec as well as another piece. So what happened? Well, this is an analysis of a data set. Once again, we weren't able to get the data before, but now I can. Total infusions in the period from April 24th to May 20th, so the Ottawa Hospital, we did 41,000 infusions in that period of time. The nursing staff, their compliance with the drug library software is measurable. We can now determine whether they're using it or they're just programming themselves and saying it's drug X and they don't identify the drug, right? If they don't identify the drug, it tells us that, so the rate of compliance with the technology, 95.3%, right? So that's not measurable. And if it falls or isn't bad in a particular area, you can go to that area and say, why are you not doing this properly? Because if you don't engage the drug library, you don't engage the safety limits. So the database that we extract we did shows that the number of times the hard limit pullback or hard limit trigger occurred was 35 times per day for a rate of 2.3% of all infusions. And the soft limit pullback was 1%, so total pullback rate of 3.3%. That number should sound familiar to you. Okay, 3%. That's kind of the same order of magnitude as the adverse drug event rate, isn't it? It's kind of in the same range. This is what you would expect. Training, professionalism will get you down that low. They will get you down to a small number of events, but that's as far as it'll get you. It won't get you this, right? Only complex technology intervention is going to get you that last few percent out. So what that means is, those hard limits means somebody identified the drug, they programmed the pump, and they pushed run, and the pump said, that's a bad idea. You should not be pushing run on this. So these are things that would actually have occurred. That's what it looks like. This is, once again, extraction from that data set. I had this file reviewed to confirm, and of the cases, we eventually arrived at a number of 1.5% of, roughly 1.5% of harmful events per day that are being avoided by this technology. Once again, I don't know if there's any clinicians in the audience. You just look at this list that I found in there. The first item on the list, that's nitrogen mustard. That's nitrogen mustard, for God's sakes. Somebody pushed run in order to look like that, and the pump had to stop them? Now, is it possible that the person who programmed the pump would have realized moments later that was wrong? Yeah, probably. But the point is they pushed run. Right? Dilantin, 300 milligrams a minute. Everyone knows Dilantin is run at 20 milligrams a minute. I've known that since I was an intern. Somehow, somebody programmed it wrong. Do you want to go re-educate them? You want to take this technology away and try it? Let's write a policy that says don't do Dilantin that way. Dilantin is, in case anyone doesn't know, is a class 1C antiarrhythmic. Like all antiarrhythmics, they cause arrhythmias, right? As does procainamide, which is the fourth one on the list, right? They cause arrhythmias. That's the point. Yes, they help, but you don't run them in fast. That's a bad idea. So these are real. This is the kind of thing. You want excellence, you want those numbers to go down. This is the kind of thing. I want to be clear. Nothing I'm describing is a magic bullet. These are all pieces that you have to think about if you want to gradually start chiseling away at issues around quality and safety. It's hard work, it's expensive. Okay. Let's get back to saving lives. So I'd like to think I've pontificated enough to convince you that policies, posters, sticky notes, in-services, more new forms for the hospital, and lots of shouting aren't really very good tools to deliver quality. You can do it if you want. I'm not sort of saying it never works, but they're not good tools. Ottawa Hospital has a business case, and we've currently installed hundreds and hundreds of spot vital signs machinery at every bedside in the med-surg areas of the hospital, the acute care areas of the hospital, not the critical care because they use a different type of monitoring technology. We have hundreds of these things. And e-vitals went live back in August, so this is what it looks like. And we're now using it on a regular basis to track our patients. And you can see in this particular representation on our electronic medical record, all those, in the center of the screen, those little numbers, a little circle around those computers saying, these numbers don't look good to me. They look bad. You probably want to look at this a little bit and try to figure it out. And you can see that the team, in fact, did intervene because you can see how the numbers resolve after that period. Making information available. Step one. Got the information. Let's revisit Lewis's vital signs for a second. This is from the Sunday into the Monday morning when he died. This is the numbers that the clinicians involved were ignoring. But you all know that it would not be difficult at all to use analytics to watch these numbers, fire off critical alerts, and communicate with care team members. Human beings are wonderful creatures. Their ability to be subjective and emotional is really wonderful. Being subjective is also really bad. Computers, of course, don't get emotional. They don't do subjective things. They apply rules blindly and sometimes inappropriately. But the other advantage is they are objective. The computer would have looked at this number and said, something really bad is happening and you guys are not seeing it. Could easily have done that where subjectively they ignored it for various reasons. We have not done this at the Ottawa Hospital, but we will. So how do I know this will work? Well, funny you should mention that. This is a study published in the BMJ back in the spring. Impact of introducing an electronic physiologic surveillance system on hospital mortality. These guys in the UK implemented an early warning system in these are two different hospitals. And if you look at the bottom line here, crude mortality fell from 7.75 to 6.42% in one hospital and 7.57 to 6.15 in another hospital. Do you think this will work? Yeah, that'll work. Mortality rate didn't fall to 0, I'd like to point out, but it fell. Does it sound like this will work? Yeah. One of the pieces of a whole series of things that you have to think about doing to achieve excellence. No magic bullets here. Piece by piece by piece, you can build this and take advantage of systems, standardization, automation, and yes, some policies and education to improve the performance of the healthcare system, and most importantly, provide feedback and metrics to members of the care team so they can assume their professional accountability, which they are prepared to do. Provided the information is given to them in a way that's appropriate and specific, they will respond to it. They're not stupid. They will respond to it. They do need feedback that is directly relevant to them and that has meaning, and they'll act on it.